afternoon, and welcome to our first virtual Vantage educational series presentation. The goal of our series has always been to give you the best information from the best specialists on topics that you've told us you'd like to know more about. With the COVID shutdown, we had to find a new way of getting that information to you while giving you an opportunity to communicate with the speaker. And we do that through a chat box. So if you will type your questions, we will ask Dr. Bunn at the end of his presentation. The, vir- the virtual series is our answer to your desire to continue your learning experience. Until we can once again meet again in person, we will provide the very best presentation from the best presenters through Facebook and YouTube. I will still send the email reminder on the Friday before the presentation. If you miss a presentation or you would just like to go back and watch it again or find the answer to a question you have, it will be there for you. As usual, we still want to know what your interests are, where they lie. Please send those to us. You can just type them in that chat box, and I will continue to look for presenters in your areas of interest. Today's presentation, minimally invasive direct anterior total hip replacement. Dr. Kevin Bunn is one of the few orthopedic surgeons in North Louisiana performing this surgery, and he is the only one in Northeast Louisiana. A native of Marietta, Georgia, orthopedic surgeon Kevin Bunn has been a welcomed addition to our Affinity Health group. After graduating from the University of Georgia in exercise and sports science, he developed an interest in joint replacement followed by hip replacement, which led him to medical school and orthopedic surgery, and we are so glad. He has over 5 years of experience in orthopedic, reconstructive, and joint replacement surgeries. He's presented at numerous orthopedic conferences and has published in medical and orthopedic surgery journals. After practicing in large cities with longer commutes, delayed traffic jams, and fighting bigger profit margins for companies, Dr. Bunn and his family chose Monroe for the slower pace and a patient-centered medicine with the Affinity Group. He liked the idea of treating the whole person with general practitioners, cardiologists, urologists, all working for the health of the patient. Dr. Bunn sees patients of all ages and orthopedic problems of all types. His patients say they like the attention and care he gives them, the way he listens, the way he continues to follow their progress. So, get your pens and your paper ready to write down those questions, and let's welcome orthopedic surgeon Kevin Bunn.
Thank you. This is the best looking virtual audience I've ever had. Wow, tough crowd. So again, Dr. Kevin Bunn, as Shara introduced. I'm going to be talking about direct anterior hip replacement. Many of you may have heard about this before. If not, this will be an educational opportunity for you to learn about what that is. I'll go through some talking points. At the beginning of my presentation, I'll go through a few slides I've talked about before at some of my other presentations for those of you who've been here and seen me talk about some other topics. But I appreciate you taking time out of your day to listen to us. And if there's any questions, something doesn't make sense, please send a message through the YouTube or Facebook, and we'll answer that for you after the presentation is complete. So background, as Shara mentioned earlier, from Marietta, Georgia, which is a little bit north of Atlanta. And the reason I put some of these pictures on here, the big chicken is the picture at the top. So that's a Kentucky Fried Chicken that has this, for some reason they decided to build a big chicken on top of it, and that's always a landmark in Marietta. All the car dealerships and restaurants always use that as a landmark, and they'll tell you it's 2 miles east of the big chicken or 1 block south of the big chicken. So that's always something, for whatever reason, people know Marietta for. Even people I knew that were from other states, I told them I was from Marietta, Georgia, knew about the big chicken. It's kind of a dumb thing, but I put it on there just as kind of an inside joke for others. And below is a Marietta Square. It's just in downtown Marietta, just a nice area in the downtown area there. Then after I graduated high school, went off to the University of Georgia. The Bulldogs, who seemed to always be a key opponent for LSU to let them win championships. So we appreciate giving you guys the opportunity to win national championships at our expense. But we try to do our best, but it's not always good enough to compete with the LSU Tigers. So I spent 4 years there, worked as an athletic trainer for some of the athletic teams, worked for the football team, men's basketball team, baseball, and women's soccer teams while I was there. And had developed an interest in orthopedic surgery at that point. I was able to go to the operating room with several of my athletes that I worked with when they had their knee scopes or ACLs done. And during that time really got interested in orthopedic surgery, but I already had a master's program set up for athletic training to go for an extra 2 years up at UNC Chapel Hill, where I went and spent a couple of years working with the field hockey team and the track and field teams, sort of in the same capacity. I also worked at the physical therapy clinics, had opportunities to go in the OR with several of my patients as well, which further fueled my interest in orthopedic surgery. And then decided to go to medical school and stayed at Chapel Hill again for another 4 years. And during that time, try to keep an open mind as far as what specialty I go into, but I really liked orthopedic surgery the most of all the specialties, and really liked the surgical procedures, and also the fact I was able to fix problems. A lot of the other specialties, I felt like I was more cutting out something like cancers or some other problem instead of fixing the problem, which is what I liked about orthopedic surgery. Mostly joint replacements, like fractures, you're able to fix a broken bone. It makes sense to me how you see a broken bone and then you put it back together, put a metal plate and screws on it, and it's fixed. And same with the joint replacements. You see a bad joint that's worn out, you're able to get that fixed with metal and plastic. So I really like that type of procedure, and really what interested me and brought me into orthopedic surgery. And tried to get away from North Carolina, but stayed for another 5 years. Just couldn't quite get away from there. So I stayed another 5 years at UNC, and we also spent some time out in Raleigh at one of the big trauma hospitals, and had a pretty good experience, and really was kind of between sports medicine and joint replacement. Really liked the joint replacement procedures better, and decided to further my training. I went out to Houston, Texas for a year, mostly did hip and knee replacement. We did a lot of the primary knee replacement, primary hip replacement, and also the revisions, which is when somebody has an implant that's in there that failed for either, for multiple reasons, either wore out because it's been in too long or had some sort of other issue. And so had done over 1,000 hip and knee replacements at that point during that year. I was exposed to the anterior hip replacement. I was able to do some labs on that before I even went to fellowship, but really never had the hands-on experience doing the operations until my fellowship. And so that's really what opened my eyes to anterior hip replacement, and saw the patient had better outcomes. And there's a lot of other questions I'll answer for you in a few minutes about why I chose to do the anterior hip replacements. And so I spent that year in Houston, and then went out to East Coast, practiced. And as you can see from the traffic there, can't really remember why I left there, but here people complain about traffic, and it maybe takes you 10 or 15 minutes to get across town. Sometimes in traffic in Atlanta, it would take 10, 15 minutes, and you maybe go half a mile if you're lucky. So sometimes I would see signs on the interstate that would say exit 0.9 miles ahead, estimated time 75 minutes. So you could be sitting there all day just waiting for traffic. And I live 7 miles away from the hospital, and sometimes it'll take me an hour and a half to get there just to show up for work at 8 o'clock. So it's just a nightmare dealing with that, plus having to drive to four offices, 2 hospitals, a surgery center, and dealing with that all day. It was not fun. Sometimes 4 or 5 hours in the car, and hospitals that were going bankrupt and having other financial issues. Just not a good situation. So at one point we looked into new positions in the group of affinity here. The opportunity was too hard to pass up. And I really liked the organization and what they stand for, and as far as the opportunity here, I felt like there was going to be enough need for myself here, and I felt that my family would be comfortable, and we decided to move out here, which has been about 2 years now. So we've really enjoyed it so far. So Affinity Health Group, my office is over at Oliver Road. It's near an intersection of Oliver and Louisville, near all the car dealerships, and there with a lot of the other the primary care practices, but it's a convenient location to get in and out of. So now we get to the meat of the talk. Now you've gotten all the boring stuff out of the way, talking about me. So we'll talk about you and your hip replacement that you may or may not be in the market for, or one of your family members or friends may be in the market for. So what exactly is direct anterior hip replacement? Before we get into that, I'll answer a few other questions that'll lead up to what anterior hip replacement is and why that's of interest and why that can be a benefit to you. So first, who needs a hip replacement? You hear about people getting hip replacements, but why am I having to get a hip replacement? What's wrong with me? What's the issue? The majority of the time, it's for arthritis. So you hear about people have arthritis. They'll come into our office and say, my whole body's eat up with arthritis, or arthritis runs in my family. There are different types of arthritis I'll talk about on the next slide, but as far as the majority of cases, it usually has something to do with arthritis. And other indications will be fractures. So we may have a patient who comes in and breaks their hip. So if you have somebody who gets a femoral neck fracture where they basically break below the ball of their hip joint, they may have a good reason to have their hip replaced. And a lot of patients, if they're healthy, I'll go ahead and do a total hip replacement for them instead of a partial hip replacement. Most of the other surgeons around town will do the partial hip replacements instead, but if anybody who's healthy enough that I think they'd ever benefit from having a total hip replacement, I would go ahead and do the total hip replacement. And I'll show you pictures and x-rays of that in a few minutes. Another indication for this would be avascular necrosis. So sometimes you'll hear about patients who are pretty young, maybe in their teens or 20s or 30s, that had a hip replacement. You say, wow, they had arthritis at a young age. That's crazy. It's not arthritis, it's avascular necrosis, which a lot of times what that is blood flow is cut off to the ball part of their ball and socket joint. And what happens with that, it can be from genetics. So some patients have sickle cell anemia or sickle cell trait. They could have other conditions that cause it. It could be from chronic use of steroids. So patients that take a lot of steroids for medical conditions or for asthma can have that. It can be alcohol related. It can be certain medications, HIV medications that can cause it. Several other causes as well. Those are probably the most common. So you may see that in some young patient having it, the hip replacement done very early. That's probably why they had it done. But occasionally do have somebody have arthritis when they're at a young age, but much more rare. What's arthritis? It's really inflammation of the joint. So itis is inflammation, and then arthra, that is the joint. So it's inflammation of the joint. And what happens when you have inflammation of the joint is the cartilage wears thin. So you'll see somebody talk about they have bone-on-bone arthritis. It's because the cartilage is worn thin to where there's no space in between. So I'll show you an x-ray in a few slides that shows a normal hip joint and a bad hip joint, and basically the space is the cartilage and it's worn out. Different types of arthritis. Osteoarthritis is the most common. That's the one that's associated with aging. But again, doesn't mean you have to be 80 years old to have osteoarthritis. You can have it when you're in your 30s or 40s. That's more common as you get older. Most of the patients that have their hips replaced from arthritis are usually at least 40s, but maybe in the 50s, 60s, or older. Inflammatory arthritis. You hear about rheumatoid arthritis. That's the most common, but besides that, and gout. And there's other psoriatic arthritis and several more that are less common. Those are the ones you hear about, patients that have it maybe at a younger age. And post-traumatic arthritis, you'll hear about somebody who broke their hip and then a few years later had to have a hip replacement, or they dislocated their hip, had to have a hip replacement, something like that. That's post-traumatic arthritis, and that can happen in any joint. And really, any of these conditions I'm mentioning here can be in any joint in your body. And then osteonecrosis, that's the avascular necrosis I mentioned in the last slide. That can also develop into an arthritis later on down the road if it's progressed for a while and the joint completely wears out. And again, here's arthritis. So joints where two or more bones meet. So again, it can happen at your knee, your hip, elbow, really any body part where it moves back and forth. And so if you imagine a hinge on the right, you see the top one, it's a nice smooth hinge, should move smoothly, shouldn't make any noises, should be easy. If you want to open that door, it shouldn't give you trouble. The hinge on the bottom, the rusty hinge, it's going to make some noises when you move it. It's going to be hard to move, maybe even have some little things fall off, like some rust that falls off whenever you open it. That's an arthritic joint. A lot of patients have loose bodies in their knee from arthritis. Little pieces of cartilage will start breaking off and start making noises. Hard to move, it's very stiff, may not even go all the way bent or straight just because it's so eat up with arthritis. Whereas on the top joint, or the top hinge, it can bend and open like it's supposed to. And again, what body parts are involved? The hip I put at the top since that's what we're talking about today, but really any body part, you can even have it in your jaw. We'll hear people that have, they call TMJ, where their jaws has arthritis. So it can really happen anywhere in your entire body, but the one we'll talk about today will be hip. And what symptoms do you have? Most significant, and why you usually come to me, is that you have pain. A lot of patients can deal with it being stiff, maybe a little swollen, but pain is usually the biggest problem. If it interferes with their daily activity, or they can't go for a walk, can't spend time with their grandkids, can't work, that's usually when patients will come to me to get their hip or their knee or shoulder taken care of. You may have stiffness. So again, like I mentioned on the last slide, it may be stiff to where you can't completely move the joint around. There may be a deformity. So sometimes you'll see patients maybe at the mall or somewhere, and you'll see somebody, their knees are really bowed in or bowed out. A lot of times that's because of arthritis. So that cartilage is completely worn out, and it's even worn into the bone to where the bone has a deformity in it. So those patients a lot of times will have a bad deformity of their leg. There may be swelling. That's from the inflammation. Weakness of the joint, and also the muscles around the joint. And then instability. So sometimes if it wears out really bad on one side, the knee joint or hip joint, it's not going to be a smooth surface, so it may pop in and out of place. So some patients will say they feel like their hip pops out. That may be why it is, because the joint's not even, and it shifts around when they're walking. So this is that slide I was mentioning earlier. It shows the normal joint space versus the arthritis. The picture on the left shows normal joint space. So in between the ball and socket of your hip joint, you can see a space there. The picture on the right, that space is gone. So that's where the cartilage is worn thin. And the cartilage is the space in between. So there's bone spurs also, they're labeled on this slide. You can have bone spurs, you can have flattening of that ball. So you see it's still kind of a round shape on that picture on the right, but sometimes we'll see it where it almost looks like a raisin or a mushroom. And that's when the arthritis has really progressed. And in the avascular necrosis condition I mentioned earlier, that's a lot of times what we'll see as well. So somebody may be a young patient, but they may have a ball that doesn't look like a ball anymore. I saw a patient in the office yesterday that they had bad hip arthritis in both hips. One of them still looked like a ball that was collapsed. The other side of the ball is completely eroded. There's no ball left at all. So that's a patient that's a good candidate for hip replacement. So what is a total hip replacement? So we saw that last slide, arthritis. So we got to do something about it, right? We have to be able to replace that joint, take that bad cartilage, that bad bone out of the joint, and put something in there to replace it. That's what the hip replacement is. So if you look here at this picture, this is an implant. It's not in a patient's body. It's just out as an example. The part on the left, kind of that round-looking part, that's the new socket. That goes up into your pelvis. And I'll show you a picture of an x-ray in a minute just so you can see where that goes. And that part in the middle, that's a pink color, that's a ceramic ball. So that's basically what replaces the ball of your hip joint. That white part in between, that's a piece of plastic that substitutes for your cartilage. And then the part on the right, that big metal piece, that goes in the femur or your thigh bone, and that goes into the bone and basically replaces that neck that the ball sits on. And all these implants have a porous surface, which is almost like sandpaper. Your bone grows into it. So with time, it becomes a permanent bond with your body. So you don't have to worry about loosening and moving around. Here's an x-ray. This is one of the first hip replacements I did probably about 5 years ago when I was in practice. A patient that had bad hip arthritis. And just like I was showing in that last image, the part at the top of it, that round part is the part that goes in the socket. I put a screw in this patient's hip to help hold it. Sometimes I do, sometimes I don't. And then that stem that goes down that femur, the thigh bone there, is a part I showed that was on the right side of the screen on this last picture here. So that's in the patient. And after that, you're able to put weight on it, walk, get moving, which we'll talk about the rehab and the post-operative course in just a few minutes. And there's different types of bearings you can use. So you may have heard about these lawsuits that these lawyers would get on TV and talk about metal hips, and that was pretty popular back in the 90s and early 2000s. That's gone by the wayside. There's still some surgeons in Europe that use it just because the implants supposedly were supposed to last longer. It wasn't going to wear quite as much, but it created metal particles that would get in your bloodstream and also get in the surrounding tissues, and your body would attack that, and you'd have all kinds of issues with that. The implants would fail. Your muscle would get destroyed by your immune system, and then you could also have effects in your entire body. It would almost be like lead poisoning. You'd basically have poisoning from these metals. So that's been basically pulled off the market in the U.S. Now most patients are either getting the plastic on the metal or plastic on ceramic. And so you see over here this top picture, top left, that's the ceramic on the plastic. And that's what most patients are getting now. The wear characteristics are a lot better. The plastic's not going to wear out as fast. The ceramic's not going to wear out as fast. The one to the right, the top right, that's the ceramic on ceramics. That's another option, but not use that frequently because there's squeaking involved and even fracture of the two pieces of ceramic hitting each other. But the early stages, a lot of patients would have squeaking at their hips. So Jack Nicklaus was a famous golfer, had his hip replaced back in the early 2000s, and he had a ceramic on ceramic, but every time he'd walk it would squeak. And so that was the first generation of these type of implants. So a lot of patients didn't like that, didn't want everybody hearing them walking around, and they couldn't sneak up on anybody, so they had to take that off the market. But they did come out with some newer ceramics that do not have the squeaking, but still a lot of patients aren't going for the ceramic on ceramic at this point. The bottom left is the metal on plastic, which is still pretty common for a lot of folks, but the ceramic on plastic is more common. And then the bottom right is the metal on metal, which is very rare to see now. Most of those implants are recalled. And then we talk about the minimally invasive surgery for hip replacement. There's different types of incisions. They're listed here. Some of them have been fads as far as doing two tiny incisions to try to do the hip replacement. Some of them are just doing the posterior from the back of your hip, or the anterior, like we're talking about today. The anterior, the benefits of that I'll discuss a little bit later, but really as far as the benefit from that, it's because you're going between muscles and not through muscles. The location where you're going is a shorter distance from the skin to the hip joint, and there's really not a lot of muscles in between, so you're able to get to the joint without having to cause significant damage. From the back of the hip, you're having to cut through a substantial amount of muscle, which I'll show you in some later slides, and that's why patients have a limp and have a lot of soreness and pain afterwards. And also it's a higher rate of dislocation from going from the back of your hip, and I'll describe that to you as well. And so here's these approaches. So again, anterior's coming from the front, posterior's from the back. And then if you can see some of these other pictures here, the one in the bottom middle, that's the anterior approach. So you can see the arrow where it has all the AMIS approach listed in the blue arrow. That's starting at your skin, and then where the arrowhead is at the bone. So you can see it's really not a big distance to go, and really just go between the muscles. And so we kind of work around the muscle and move the muscle. You kind of pull on it just to get it out of the way to be able to get where we need to be, but you're not having to cut through muscle, which is nice. The posterior is the one on the right. If you look at that right picture, the top left, it has an arrow saying posterior approach, and that's going right from the back of your hip. So your gluteus maximus muscle, which is the biggest muscle group in your body, your buttock muscle, where you basically sit on every day, that muscle is having to be cut through to the posterior approach. And so that's why it's so painful and sore. And additionally, there's some deep muscles you're having to go through as well. So why direct anterior hip replacement? Finally, this is what I came to listen. He's been blabbing on for 20 minutes talking about something else. Finally, he's answering my question. Why direct anterior hip replacement? So there are several large studies, probably the largest one's at Mayo Clinic, that shows that the recovery is faster. So long term, if you look from a patient has an anterior hip replacement done now versus a patient has a posterior hip replacement, you look a couple of years down the road, they're probably doing just about the same, assuming the implants were put in properly. Those patients should be doing pretty similar. Even several months down the road or a year down the road, they're probably going to be doing about the same. But the early stages is the main reason you want to have the anterior hip replacement. So the advantages, I listed quite a few of them on here, but I'll go through each one of these individually. But the less pain, that's mostly like we talked about earlier, not having to cut through as much muscle or through any muscle like you're having to for the posterior. So you may pull on the muscle and may get a little bit irritated from getting pulled, but it's not getting cut through. And so I'll show you another slide about the healing of muscle, and it'll show a lot too, which will make sense. The faster and easier recovery, like we talked about, part of it's because you're not cutting through muscle. Also, it's the direction where you're going through the hip. Coming from the front's easier than from the back, and I'll show you why that is a little bit later. And because of that faster recovery, a lot of times it's earlier hospital discharge. So, I mean, even patients who are having the posterior hip replacement still usually go home within a couple days, but maybe 1 or 2 days less with the anterior hip replacement. And those patients are usually doing better when they go home. It's easier for them to get up and out of bed, easier to walk, easier to get around. So they have to rely on their family and friends a lot less than posterior hip. And all these patients are getting rid of their canes and walkers quicker. I had a patient come to my office on Monday. She was 2 weeks out, or less than 2 weeks. She was 13 days out from her hip replacement from the front. Didn't have to use a cane or walker or anything. She brought it with her just in case she needed to, but didn't need to walk with it at all. Pretty rare we have somebody with a posterior hip replacement being able to do that well that quick. Usually it's still 6 weeks and they're at least using a cane, maybe even still a walker. So it's definitely a quicker recovery. Fewer restrictions on the activity. We'll talk about that in a few slides as well. As far as people you've known who've had hip replacements, they had to wear these fancy pillows on their hips and they couldn't bend over to tie their shoes for a while. There's a lot of things they couldn't do. That's something you don't have to worry about with the anterior hip replacement, because as the next bullet point says, there's a lower risk of hip dislocation after surgery. So that's the main reason you have to avoid those movements, is you don't want your hip dislocating, which means popping out of the joint. And I'll show you a picture of what that is, and just by seeing the picture, you'll understand why it hurts so much. And then there's lower risk of dislocation, not only dislocation, but also the leg lengths being different. So you'll see a lot of times, I heard a story just a few minutes ago about a patient having their hips done, and one of them was a lot shorter than the other or a lot longer. That's something by doing the anterior hip replacement, you can actually see better on x-rays to make sure there's not a leg length discrepancy. Excuse me. And why is there less pain? I mentioned about it earlier, is because we're not having to cut through the major muscles. So again, that gluteus maximus, which is that major muscle in the back of your hip, you're not having to cut through that. And there's another picture here on the right. So if you look here, this is after the gluteus maximus, the big muscle has been cut through. There's all those small muscles here, and you're having to cut through those as well. So in addition to the large muscle, you're having to cut through maybe 5 or 6 more smaller muscles in the hip just to get down to the hip joint. That's going through the back of the hip. From the front, you don't have to do that. You see that picture on the left, it shows the hip joint, but I'm not having to cut through any muscle to get there. They have those retractors, those metal things that are in there. They're holding everything away, but they're not having to actually cut through the muscle. And so here's where the incisions, the middle slide, or the middle picture shows you the incisions. So the anterior hip replacement, the blue line there in the front, which is on the left of that picture, that's a smaller incision usually. It's in between the muscles, and then the one on the right, that red incision is right through the big muscle. And why is that recovery faster? Like we mentioned, not having to cut through the muscle. And you can see this picture over here on the right side of the slide. It shows healthy tissue. So this is what it looks like before an injury, before surgery. And you see how those muscles look nice and smooth. The lines go up and down. And imagine that muscle looks the same after an anterior hip replacement, because I'm not having to cut through the muscle or injure it. And then if you look on the middle slide, or the middle part of that slide, which shows injured tissue, that's right after you cut through it or you just have to sew it back together. So that tissue is under a lot of strain. It's having to re-heal. So that function isn't quite as good. There's a lot more pain. And on the right side is when it's scarred in. Instead of healing in with normal muscle tissue, it actually heals in with scar tissue. So again, decreased function, higher risk of re-injury. So you can actually injure that muscle years down the road just because it didn't heal properly. And so it's a disorganized type of tissue instead of the muscle tissue that you have. And so that's the benefit of doing the anterior hip replacement for muscle. And then so the faster recovery. So again, like I was mentioning earlier, not having to use the walkers, canes, or other assistive devices as long. So it's at least 5 to 7 days sooner, depending on the research you look at. Which is nice. No one wants to have to carry a cane around and walker, and just cumbersome. Makes it hard to get around your house with a walker. So it makes it a lot easier for the patients, and they feel a lot less self-conscious when they don't have to carry a walker or cane around. And this is just kind of a busy slide, but there's a lot to cover on here. So why are there fewer restrictions? So I mentioned earlier the risk of dislocation is lower, and why is that? So posterior hip replacement, there may be several motions that you can't do, and I'll show you a slide in just a minute that shows all those motions that you have to avoid, usually for about 6 weeks. And the reason is because you can dislocate your hip, and that's a big problem. If your hip pops out of place and doesn't stay in place, you're going to be in trouble. You may have to go back to the OR to have your hip done again, which is the last thing you want to do. You just went through one big operation to fix a problem. You don't want to have a new problem that's been created. So that's one reason with those precautions, you're really trying to be careful and avoid bending forward so you don't have your hip pop out of place. And not only does it mean it's out, your hip's out of place, it's painful. So imagine if your hips all of a sudden just popped out, it's going to rip through those same muscles that you had repaired. It's going to be a traumatic experience for these patients. So that's something they don't want to go through. And so there's a lot of precautions just to prevent that from happening. With the anterior approach, because we go from the front of your hip, and I'll show you exactly what the anterior precautions are, what you have to avoid. It's nothing that most patients really do. So because of that, you're really not having a chance of it popping out of place, just because the motion to pop it out of position is very, very difficult to do. So a lot of patients, after my operations, will not have any precautions at all, or they have very few, and so they're able to do most things and have to think about what they're doing. And so here's the posterior hip precaution. So on the right slide over there, I'll show you a dislocated hip. So that's what would happen if you bend over too far and dislocated. So you pop out of place, it'd pull a lot of those tissues, and it'll tear a lot of the muscle that you had repaired during surgery. So that's going to further make the healing process harder for a lot of these patients. If they just went through a big operation, plus now you've torn tissue around your hip, that's traumatic. The two slides on the left, or two pictures on the left, show you those hip precautions. So it's either, depends on the surgeon. They may say don't bend past 90 degrees, don't bend past 80 degrees. So bending forward, you have to be really careful sitting in a chair. Can't tie your shoes, can't put your shoes on or your socks on by yourself, or you have to use these little grabbers to do that. Can't cross your legs over, which a lot of patients may not be able to do after surgery anyway, but still something you have to worry about. And you can't roll your leg forward, so you have to be very, really careful. Patients after the posterior hip replacement can't sleep on their sides just because you're worried about having that hip cross over the midline of your body and dislocating. So there's a lot of precautions they're having to avoid. So, or a lot of movements they're having to avoid. So that's why they have those special pillows a lot of patients are using, or putting pillows between their legs for 6 weeks or longer sometimes. It's because of that. And that's something that really is difficult for a lot of patients to remember. They can't bend forward, especially some of the elderly patients. So I mentioned earlier, one of the reasons to do a hip replacement is a hip fracture. So a lot of those hip fracture patients are elderly, and some of them may have dementia and can't remember to do these precautions. They can't even remember their name sometimes. They can't remember to take their pills. They're not going to be remember not to bend forward. It's something they've been doing their whole life, and try to tell them they can't do that. It's going to be very difficult. So that's another reason that the anterior hip replacement can benefit that patient. So here's the anterior hip precautions. So here's what you can't do if you have the anterior hip. So limbo, that's about it. So anybody here at limbos? Anybody? Exactly. So there's no one. So I'd be hard pressed to find too many people that were upset about not being able to do the limbo. It's pretty hard to dislocate your hip from the front. During the surgery, we have a special device I'll show you that we use, a special table. And I'll actually put your hip in kind of a limbo type position to see if it pops out of place, and I'm pulling on it and it still stays in position. So really chances even doing limbo popping out are very difficult. So chances of the hip dislocating is almost none by the time we're done with this operation. So again, the fewer dislocations, because it's an unnatural position. Unless you're somebody that's something you do all the time, you're probably not going to dislocate the hip. I mean, certainly you could dislocate your hip if somehow you got yourself in a funny position and fell and fell, and had your hip in that extended position, but it'd be very unlikely for that to happen. Probably the only times I've seen it happen on the anterior hip is somebody fell and actually broke their hip below the implant, and then it dislocated at the same time just because it shortened down the joint. But as far as just regular wear and tear, it's very unlikely for something like that to happen. And then also the implant position. So one thing that can cause dislocations, not just going from the back of your hip, and I mentioned earlier that the posterior hip replacements are a higher risk for dislocation. Doesn't mean all those dislocate. I don't want to scare everybody to feel like that's something that happens. As long as the implants are put in the proper position with the right rotation and the right sizes, then there's a very low risk of that happening as far as the dislocation. So even a hip done from the posterior, from the back of the hip, if it's done right, it's still a very low chance of dislocating, but you're not able to assess exactly how well you put the implants in very well doing it from the posterior approach. From the anterior approach, it's very easy to get x-ray in there to be able to check and make sure the implants are in the right position. You can do that from the posterior approach. It's just very hard to get good x-rays in. I've been at hospitals where the x-ray was not digital, so they have to take an x-ray shot, go off, put it in a computer somewhere else across the hospital, and have to wait 15 minutes for it to load up on a computer. And if they didn't get the right angle with their x-ray, they have to shoot it again. So sometimes it would add 30 or 45 minutes to the case just waiting for an x-ray. For this, it can take a matter of seconds. I can look, and as I'm putting the implant in, I can make sure it's in the right position, and then we can move on. So by the time we finish the operation, there's no guesswork. I know exactly where the implants are put in. I'm happy with how it looks, and not going to have any surprises when the patient gets out to the recovery room. So that's the other reason there's the lower risk of the leg length discrepancies. So as far as the patient having a really long leg or a really short leg after surgery, that's not going to happen with the anterior approach. If I'm using my x-rays, I can look and see exactly the length and know if we're off. So if I'm in here and I see this patient's going to be a little short, I'll just add some length to the implant. If it's going to be long, we can take some length off. And that's the good thing about this as well. We can do this very quickly. It only adds a matter of seconds, and we can check it throughout the operation. So we can check the implant length As far as your leg lengths, we can check the sizes of the implant, so I can tell if the implant's too small and we need to go up to a bigger size. I can see all that in real time. And I didn't mention this earlier, but there's also a lower risk of foot drops. You may have heard about patients having hip replacements, and now they're having to wear a special brace on their foot. They can't lift their leg up. Their foot's dragging, it's the foot drop. And what happens, there's the sciatic nerve, which goes right behind your hip. And remember showing you all those muscles that the posterior hip you have to cut through. That sciatic nerve is right next to it. So you see right there on the right of that screen, piriformis is one of the muscles that gets cut through, and those other muscles right below it, and then the sciatic nerve runs right there. So there's always a chance you could either cut through it or stretch it during that surgery. And so that's why the risk of the foot drop is there. It's very low with the anterior hip. I've never actually seen it happen with the anterior hip replacement, but it's happened quite frequently with the posterior approach. I bet most people who do the posterior approach probably have at least one of these every year or two. It just happens just because it's pretty common location, and also the exposure. Even if you're being very careful not cutting the nerve, it just gets pulled because you have to put retractors in there to pull at the hip, and those retractors are very close to that nerve, so it can put some stretch on it. So it happens quite frequently. There is a nerve that sometimes can get a palsy, which is basically an injury to it from the anterior hip, but it's a little skin nerve that goes to the side of your thigh. And so patients after the anterior hip replacement may have a small patch of numbness on the side of their thigh. Not always, but if they do, it's usually nothing that really bothers the patients. They'd rather have a painless hip and have a little numb spot on their thigh than to have the painful hip. So it's very, very minimal if there's any problems with that. And any kind of special equipment that we use. So here's the one device that we have over here. Unfortunately, there's only one in town right now. They're working on getting another one at one of the other hospitals. But right now at PNS and St. Francis, we have the HANA table, and they share it back and forth depending on the availability of the rooms or where I am doing the operations. But this table, the special part about this is, if you see this patient here, his right leg, the one that's aimed towards the ground, that's his operative legs. That's the one that he'd be having the hip replacement on. And so what you can do is with that table, you can manipulate the leg to be able to get it in the right position to do the operation. So without that special table, it's very difficult to get the hip in the right position to do this operation from the front of your hip. You can certainly do it without a table and just have somebody on their side if you do the posterior approach, but with the anterior approach, it's easier with this special table. There are different devices you can use to make up for it and to be able to get from the front, which some surgeons use, but I use this table here, and it definitely helps make it a lot easier exposure, even with bigger patients. So there's a lot of surgeons out there who do the anterior approach, but they only do them on really thin patients, and they have trouble if it's somebody bigger. But this table will help you even with a bigger patient to be able to do that. And with this table, I can actually manipulate the leg and move it around there to test to make sure the hip stays in place. So remember showing that limbo slide. So the same thing, we can get your hip in a really extended position and pull it over and make sure it stays in place, and I can check that. And the good thing too is you see where that blue peg is between this patient's legs. That's kind of where the x-ray machine can come in. So it slides in, and we're able to check those implants and check the sizes and leg lengths and the positions and make sure everything's in the right place before we move on. And this table is great for this. We can also use it for other procedures, broken hips, hip fractures, we can use it for that. So several other procedures besides just the hip replacement. But what it's mainly used for, what I use it for the most, is for the hip replacement. Any other technology we use? So yes, this is the x-ray machine I was showing you earlier. Unfortunately, the only picture they had on the screen on the right side of the spine, but basically the same thing. So we basically will slide in the x-ray machine in between, like I was showing you, in between the patient's legs here, and it goes over top. So this part here, this flat part on the top of the screen, that black part actually goes over the patient, and the x-ray beam comes through, and we can assess those implants as far as the positions, the sizes, the leg lengths, and so we can see everything we need to on the x-ray. And I'll look at that screen and be able to see it, make sure we're happy, and by the time we leave the room, I'm confident that everything's in the right position. And it's one thing that a lot of the people in the OR, the staff, because I'm the only one that does these up here. There's one person in Shreveport that does them, and that's about it, besides myself in North Louisiana. So a lot of them have not seen this procedure, so they're really impressed with how they're able to see the implants go in the right position. And not only I feel confident about it, but the staff as well. They feel really confident about it afterwards too. They can see it, and it's rewarding when you're able to look and see everything in the right position and know it's done right when you leave, and not have to worry about getting the x-rays in the recovery room to make sure it's in the right position there. And definitely a lot easier and definitely a lot more peace of mind. And so what to expect with the direct anterior hip replacement, you're out of bed walking the day of surgery, we get you up the same day. They'll do that with even knee replacements, and if you have a hip done posteriorly too. But just, a lot of the times the patients with the anterior hip are up faster, walking around a lot easier. The first one of these I did when I was in Atlanta practicing, and it was actually an outpatient surgery center. And so I've never done one outpatient before until that time, and I was a little worried about it. But went and did my operation, had my procedure, and I had another short procedure I went and did in between. And then I went back out there to the recovery room to check on my patient to see how she was doing, and she'd already left. She'd already gotten up, walked. The therapist got her up walking. She was gone. Probably 30 minutes later after surgery, 30, 45 minutes later, she was gone. She'd already gotten up, walked out, so she was good. And so I was pretty impressed. I was blown away the first time I saw that, and how quickly patients are up moving. So it's definitely something that if you haven't seen it before, it definitely will change you the first time you see a patient with this operation. And here we don't really do the outpatient just because there's not enough staff as far as physical therapy to be able to get up patients the same day and as quickly after, not the same day. We get them the same day, just not within an hour of surgery. So it usually takes a little bit longer just because the staff isn't devoted right for that recovery room to do that. This was at a private outpatient surgery center owned by my group I was in, so they had their own therapist ready to pounce on the patients as soon as they came out. So it's a little bit different. We're having to wait on the hospital therapist to see the patients. They may not see them for a few hours, and then they get them up walking, but at least by the next day. So one day, sometimes 2 days if the patients are a little bit slower mobilizing, but usually it's within 1 or 2 days. Rarely will somebody have to go to a rehab facility. It's usually somebody who's already deconditioned to begin with. They're in a wheelchair already, or this has been going on for several years, and they're having to use a walker and rely on a lot of help for mobilization. So those patients may require a rehab facility stay, but it's pretty rare. Most of the patients that are already walking pretty well before this will do well and just go straight home. So early work with physical therapy if it's needed. So some patients will have therapy come to their house. Some patients will go to an outpatient therapy clinic, but not everybody needs it. It's really the therapy is just getting up and walking. So if you're doing really well walking and you've already gotten rid of the walker or the cane, you may not even need to do any therapy after this. Most of the patients within a month or two are back to their full activity, some even sooner than that. I've had patients up, unfortunately, doing too much sometimes too soon, and I've had patients go up and wash their car. They're climbing up on top of their truck 2 weeks after surgery, so it can be a little bit, sometimes they move a little bit too fast for your liking. I want them to kind of ease up a little bit and take it a little bit slower than they do, but a lot of patients can be back pretty fast and get going. And then also you should expect to have the envy of your friends and family, especially those who had this hip replacement done from the posterior approach, and they had to have the pillows for 6 weeks and had to avoid bending over and putting their shoes on and had to really rely on a lot more help and had to use the canes and walkers for a while. When they see how well you've done after this, they'll be envious of you. And it's definitely things have changed, and it's a lot easier recovery and definitely worth consideration if that's something you're needing to have done. To definitely consider having the anterior hip replacement instead of the posterior hip replacement. And now we can do it in town here, so you don't have to go drive to Shreveport or to South Louisiana or to another state to have this done. And that's one thing I want to make sure, that's why I gave this presentation. I want to make sure patients are aware of this procedure being here. I've heard of some patients in town flying to Chicago and having it done, or going to Dallas, and it's something you don't have to do anymore. You can stay here and have it done locally and have your friends and family here with you and not have to travel and spend weeks at a time in a hotel in Chicago somewhere. So happy to be here, and thanks for inviting me to talk. I'm honored that I was the first virtual speaker. If there are any questions, that we can go ahead and address those now.
We have one viewer who wants to know how many hip surgeries you've done. How many have you completed so far? Have you counted?
So I lost track after 1,000. So I had to count for a while. During residency and fellowship, you had to log all your cases, and so I had a number set. And then once I got into practice, I started counting everything. I just kind of lost track once I got to 1,000. So it's somewhere over 1,000, but I'm not sure the exact number. Probably up closer to 2,000 or more by now, I'd imagine.
We have another viewer who asks, what is the typical recovery time for a hip replacement surgery?
So it really depends. I mentioned on it a little bit earlier, but it really depends a lot of times on the patient, how they are at baseline. So if it's a younger patient or healthier patient is more active to begin with, the hospital stay maybe 1 or 2 days, going home, hopefully getting rid of the cane or walker within a week. and then back to most of your full activities by 1 to 2 months, just depending on what you're trying to do. If you're really high demand and you have a very physical job, it may be more like 2 months or maybe even 3 months if you're very active. For some of the elderly patients who maybe are a little bit more deconditioned, they may have a longer hospital stay. It may be 2 or 3 days. It could be a rehab stay if they need to. And as far as their recovery, it may take them a little bit longer. They may need the walker for a couple weeks. They may need it for even 3 weeks, just depending on how they're getting around. And sometimes it could take them 2 or 3 months to really get back to where they're doing. And same with a lot of those fracture patients. If it's a fracture patient who is older, they may be a little bit slower to recover. I've had some younger patients who are in their 60s that broke their hip that bounced back, and they were walking normal within 2 weeks or so. Had one patient, he was in his 70s, broke his hip, and they decided to send him to rehab after surgery. He went to rehab. He was there through the weekend. He got to rehab Friday. By Monday, they discharged him home. So he was doing that well at rehab. He probably didn't even need to go there. He probably could go on straight home. So it really just depends on the patient. But the average patient we have, I'd say probably within 1 to 2 months, you'll be back to doing what you need to do and out of the hospital in a day or two. Just really depends on where you are to begin with.
Another question. Let's say that this person was in their 60s, but they ran marathons before surgery. Can they eventually get back to that?
So there are patients that will go back to long distance running. I do warn you, if you have the hip replacement done and running, we probably need to check your x-rays more frequently just to make sure that the plastic's not wearing out. That's the main thing you see first, is you'll see that the plastic, so let me show you one of those x-rays again. So that space in between the implant, so here on this patient's x-ray, there's a space, so you can kind of see where that ball is inside the socket. It's nice and centered. And if you start to wear out the plastic, that ball will start shifting up, because the implant, what it does, it'll start wearing on the top of that plastic, so it'll actually shift up, and the ball is not going to be perfectly centered within that socket. So if I start noticing there's some wear of that plastic, we'd have to talk about changing that plastic out. So somebody that does have a lot of long distance running and that's what they're planning to do afterwards, I would say that's fine. Once you've recovered, you could do the long distance running, but we may have to check your x-rays every 6 months or so, just to be cautious.
Okay. You mentioned something about TMJ and arthritis. I didn't know there was a connection there.
So you can develop arthritis in any joint. So I only listed more than ones that we, as orthopedic surgeons, we deal with. But yes, you can develop arthritis in any joint. So really any two places where bones come together in your body can wear out just from use. And so if you imagine your jaw, the TMJ, you're chewing all day long. So if you're somebody who's in your 60s or 70s or even sometimes younger, just you've had years and years of chewing, it can wear out. So patients do get to the point, and I've heard of them doing the replacements on that joint too. It's not anything orthopedic surgeons do. It's usually an oral maxillofacial surgeon that does that, or a plastic surgeon, or sometimes ENT surgeons will do that. But that's a different specialty. But that can wear out. Really, any joint in your body can wear out.
If you have any other questions, please ask them now.
Anything, Amy?
Okay, we have someone who has asked, where do you do your surgeries here?
So currently the hip replacements we're doing at PNS. So before we're doing most of these over at St. Francis, but once the COVID hit, we had to start doing all the elective procedures over at PNS. So really the only procedures that are done over at St. Francis are emergency procedures. So if somebody comes through the ER and goes upstairs, that would be over at St. Francis. But any of the elective scheduled procedures will be over at PNS. If somebody breaks their hip and they need the hip replacement, I would do that over at St. Francis because they came through the ER. We're also working on trying to get the table that I showed earlier, that HANA table over at Monroe Surgical Hospital. I'm not sure if that's going to happen, if they have any plans for that. I've talked with a few people about that before, and that's possibly in the works. And so that may be another option to do over there. But currently right now, as far as the anterior hip replacements over at PNS, I do the knee replacements over at Monroe Surgical and PNS right now. There's always an opportunity to go to Glenwood Hospital, but most of the patients have wanted to stay over here. That's where I spend most of my time, so I've always done them over here. And shoulder replacements the same way, so Monroe Surgical Hospital and PNS Surgery Center. But I'll take call over at St. Francis Hospital, so there's always a chance you could have that operation done over there if something happens on call.
Okay, we have the question, is there a lot of scarring from the anterior as compared to the posterior?
So scarring should be less. There's a smaller incision. Usually my incision I use is about 8 or 9 centimeters. That's usually shorter than the posterior. So as far as the incision, it's a lot shorter. And then all the deep scar tissue you have that forms underneath the skin, it's probably not as extensive just because it's a smaller amount of tissue you're going through and because there's no muscle that gets cut. So in between the muscles, you repair what's called fascia, that's a connective tissue around the muscles. You repair that, but there's no muscle you have to actually repair, so there's less scar tissue from that. As far as the incision on the anterior versus the posterior, it is a shorter incision, but sometimes you can have some incision problems if you have a big abdomen that goes over there. So what I do is I try to avoid that skin fold if somebody has a big abdomen that goes over top of it. So I'll usually move the incision a little bit further towards the outside of the hip and a little bit further down towards their knee, and just cheat the incision a half an inch or so further down just to avoid that skin fold. But still, there may be some patients who have a kind of a big abdomen that folds over top of it, that wound can take a little bit longer to heal. Those patients, probably 99% of them heal it with no problem, but just may take them a little bit longer than the typical patients. Instead of being healed in 2 or 3 weeks, it may take them more like 2 or 3 months if it's a little bit bigger patient.
Could you go back to your last page of your PowerPoint? Someone wants to know, where do you call to get an appointment?
Yep. Let's see.
And here we go.
Too far. Here we go. Went too far. Yeah, I'll put that up there for you. There you go. So there's the number. There's the address. So if you call this number, it'll go right to the front desk in my office, and Michelle, I'll give her a shout out. Michelle will answer the phone and have a big smile on her face, and we'll make you an appointment. And we have a great staff over there too. So you'll meet them. So you'll have Caitlin and Claire, the 2 nurses that work with me. There's Gerald, who is a medical assistant that does a lot of casting, and he's great. And Mark is our nurse practitioner that works with me as well. Sometimes you may see him if I'm in the operating room and can't get an appointment the day I'm there, or the day doesn't work, he'll be there. He can see you the first time, and then if you decide that's what you want to do, and I can see you. But most of the patients, if you say you want to see me, and they'll make you an appointment with me and make sure I'm there when you see me. But if for some reason I'm out that day, they can make you an appointment with Mark, and then you can always follow up to talk with me if you want to. So a good group over there, and one of their bosses is over here that runs the office. Amy's here, that's in charge, and she does a great job keeping everybody in line and making sure the office is well run. So it's definitely a good organization. You'll be very impressed with the office, how well it runs, and how everybody's really courteous and nice to you, and they'll answer your phone calls and get back to you quickly. So that's another thing. If you decide you want to have the surgery, and then you go home and you start talking to your family and they have questions, you can feel free to call us and we'll answer questions for you, or you can bring them back in for another visit so we can talk to them, or even do one of these telemedicine visits, which have been pretty popular over the last few months too, which has been nice. So you can even call in with your family members. We can talk to them on the phone. You can have them on speakerphone, and we can have a little family conference and just talk about what all is to be expected and help answer any questions you have.
We have another question. With a vascular necrosis hip patient that had collapsed, how long should your evaluation be prior to scheduling surgery?
So if you have so I'm assuming you're saying you're coming in wanting to have the surgery done. So let's say if you came in to see me tomorrow, you had avascular necrosis and you're ready to have surgery in your hip, and we feel that you're appropriate for that procedure, what we would do first is we would get you set up for your medical clearance with your primary doctor. If you're assuming you're really healthy, have no medical issues, we can guarantee that clearance will happen pretty quickly. We'll go ahead and get you scheduled. So probably within a couple weeks we could have you on the books. And if you have somebody who has a lot more medical issues that may need to see a cardiologist or see some other specialist, or if your primary care doctor is a little bit harder to get into, it may be delayed by a couple of weeks on top of that. But usually, if you really want to have this done soon, we can get you scheduled, and we're pretty flexible with our dates. And so there's some guaranteed days that I have that are my dates I can operate over at PNS, and then there's some other ones that are first come, first serve, and a lot of those first come, first serve dates are not filled. So that's one good thing is we can get you. We had that happen yesterday. Somebody came in that had avascular necrosis, and And we were thinking they were going to be having to wait till late October, early November. We found out we can get them on, I think, on October 6th, something like that. So a lot sooner than we expected.
Miss Tullis, and we've already answered that question, but she too asked, where do you call to get the appointment to see this doctor? So is that still up there?
This number's up. Yes, this is the number for the slides. If you call that number, they'll answer and get you set up.
And Mr. Rayburn said, thank you. Really good information.
Well, thank you. Thanks for watching. And if there's any other questions, you can definitely ask through the Facebook or in the YouTube apps. And if there's any questions you don't think about today, or you just want to know, or you even just want to come by just to talk about it, feel free to make an appointment. We'll answer any questions you have and bring any family you have, or anything. You can write them down on a notepad and answer. And I'm sure there's some way they can even ask after the talk too. But definitely feel free to come by and meet with us. To be happy to talk with you. And a lot of patients will be worried that they're coming by. I don't want to waste your time with this, doc. I just want to know what my hip looks like or something. That's fine too. If you just want to see, if you said somebody told me 20 years ago I would need a new hip replacement and it's still not bothering me, and you just want to see what's going on and get an x-ray, we can do that, and that's perfectly fine. Or some patients that really have no interest in hip replacement. They know they have a bad hip, but they just want to know what other options are out there. And that was one of my other talks before. I talked about all the operative and non-operative treatments for hip and knee arthritis. So that's something that happy to go through with you. Even though we really just talked about hip replacement today, there's some other options we can go through before we even get to that point. So usually when we're scheduling the hip replacement, it's somebody that has the avascular necrosis, that's bone on bone, they're miserable, they can't do anything, or it's somebody who's kind of been through all these treatments. They've tried injections, they've tried therapy, they've tried every medication, they're using a walker, they're agony and can't deal with it anymore. They're wanting to have this done. But there are some patients who it's just kind of gotten progressed on them pretty fast. And sometimes avascular necrosis patients, it can happen very quickly. And that's a condition that patients afterwards feel immediate relief. It's amazing. I think the avascular necrosis patients are probably the ones that do the best of anybody. One, because they're usually younger, more active, more healthy, just on average. And then also because that pain is so severe, the avascular necrosis causes pressure inside the bone. So a lot of people feel like their hip's about to explode and is just miserable to them. So after surgery, that avascular necrosis is completely gone and they feel immediate relief. So those patients, a lot of times, it's almost like turning on a light switch. They feel a lot better right afterwards.
Someone asked about insurance, Medicare, and also USAA. Is that military, maybe?
So yeah, definitely Medicare, Medicaid, Vantage, Blue Cross,
TRICARE.
some of the Uniteds, TRICARE we've taken, VA. Do you know about the USAA? I'm not sure. We can look into it for you. So that's another thing. If you call our office to make an appointment, the same number, they can look into it, and they know all the insurances, because sometimes there's an insurance we don't take, and they can tell you that. But most of the insurances we take, there's just a few out there that we don't. But they could definitely answer that question for you at the front desk if you call that number.
Thank you very much, Dr. Bunn. You've been very informative.
Best talk I've ever given.
Is it the only one you've done?
Only virtual one.
All right.
Thank you. You've been a great crowd. And again, if there's any questions or anything, please feel free to contact us. We'll be happy to meet you in person.
I'd like to thank Dr. Bunn for his presentation today. And I know he has others planned for the future. We hope you've enjoyed our series. And please watch Facebook for for the next one coming up. And I'll also send out a mass email so that you will know about the next one before it happens. Thank you so much, and please join us again next time.